Good morning. I'm Dr. Mary Toth. I'm a rheumatologist here in Orlando. I work at Nemours Children's Hospital. I am the division director, and I am also a professor at the University of Central Florida Medical School. I'm also the director of the Jennifer Lynn Schott Childhood Arthritis Clinic, where we offer comprehensive care for children with arthritis. Today, I'm going to talk to you about medication, remission, and the whole idea of treat to target, which many of you have heard about and some have not heard about, and what does that all mean? The goal of this talk is basically to talk about medications. I'm not going to talk about medications that are not approved for children under the age of 18. I'm not going to talk about other medications that you can buy over the counter or things that are considered alternative therapies. The goal of this is to talk about why we try to target for remission and the medications that we use to do this. I've been in practice for over 25 years. This talk 25 years ago would have been very different. So the fact that we are now talking about medication, remission, and treat to target is a wonderful thing. So the objectives of this talk is to review the classes of medication used to treat arthritis, define what does treat to target and inactive disease, remission, what do those terms mean, and talk about the parent and child role in this treat to target and remission goal that we're going to talk about. So it is important to remember that this is an autoimmune disease. Juvenile arthritis is where the immune system is attacking the joints. We at this point in time cannot cure the disease, cannot cure the arthritis, but we can control it so that we can put it into an effective remission. So the goal is to put the arthritis into remission with medications and pray over time that the body kind of fixes itself and says, I'm not going to attack those joints anymore. Once the arthritis is in remission, we want to keep it there for an extended period of time to make sure that it stays that way, because again, we don't cure it. So we want to make sure that for an extended period of time, there are no flares or relapses while you're under good control or in remission on your medications. And so you should work with your rheumatologist to find the right medications to control the arthritis and determine if and when medications can be weaned, lower doses, or even stopped. So those are the four classes of medications we're going to talk about. We're going to talk about anti-inflammatory medications, which we won't spend much time on. DMARD medications, DMARD stands for disease-modifying anti-rheumatic drugs. Those are your methotrexates and leflunomides. These are the medicines that have been around for a very long time and were the only medicines that we had 25 years ago. Now we have these things called biologic DMARDs, biologic disease-modifying anti-rheumatic drugs, that have revolutionized our treatment of kids with arthritis and have that goal, or can possibly achieve that goal, of remission or inactive disease in many children. And then the last one we'll talk about is the steroids. So anti-inflammatory medications may be effective as a single therapy in patients with the oligoarticular type of arthritis, but honestly, less than 10% of patients are effectively controlled with an anti-inflammatory medicines alone. And I apologize, I use that abbreviation NSAID, that stands for non-steroidal anti-inflammatory drug. So I apologize, sometimes I throw in these abbreviations that I use all the time and forget. Sometimes people don't know what those things mean. So in kids who have one or two joints, so the oligo type of arthritis is when kids have 4 or fewer joints. And usually if you have maybe 1 or 2 joints and the immune system is attacking just that one joint, occasionally an anti-inflammatory medicine all by itself, taken on a consistent basis, can keep up with the inflammation the immune system is producing and relieve that swelling and pain. But it needs to be taken consistently, because if the inflammation is here and the medication builds up and keeps up with the inflammation, it works. But if you take it inconsistently, the medicine never really gets to that level. You kind of get the ups and downs of anti-inflammatory effect. If it's not effective though, within 6 to 8 weeks, they're gonna need additional therapy. And unfortunately, like I said, maybe 10% of kids we see a significant response to anti-inflammatory medicines alone. Most of them are gonna need something more than that. The examples of these types of medications are your naproxens, ibuprofen, celecoxib or Celebrex, meloxicam or Mobic. Those are the most common medications that are used on a consistent basis. I personally choose celecoxib and meloxicam as my anti-inflammatory medicine because they are easier on the stomach than taking ibuprofen or naproxen. Now, many kids will still keep them on some of these anti-inflammatory medicine drugs, even if they're not 100% effective in controlling their disease. Because if we're gonna use these other medicines that suppress the overactive immune system to stop that inflammation, we may not be able to totally do it, or maybe we don't wanna totally suppress that immune system and some will slip through. And the anti-inflammatory medicines may provide that little bit of extra coverage that might not be helped by some of those other medicines, these DMARD and biologic DMARDs we're gonna talk about. Side effects to anti-inflammatory medications are most commonly in children stomach ulcers or stomach pain. So most often it's stomach pain, and rarely do we get stomach ulcers. Sometimes we can use medicines that help prevent stomach ulcers, like omeprazole or Prevacid or something like that, that can help with the lining of the stomach. But if you take it with foods, many kids don't have issues with it, but it can cause stomach ulcers. You have to be aware of that. If your child is on these kind of medications and has severe abdominal pain, it could be a gastritis or a stomach ulcer. Celecoxib and meloxicam are less likely to affect platelets, but all the anti-inflammatory medicines have an effect on platelets. Platelets are what your body uses to clot your blood. So some kids who are on things like ibuprofen and naproxen may have more problems with bruising or bloody noses because their platelets aren't as effective as they were. They still have them, they're just a little lazy and they just take a little longer to respond to what they're supposed to do. And anti-inflammatory medicines can sometimes affect the kidneys. And so if you're on one of these medications, we usually recommend that when they first start them, within 1 to 3 months, they get blood work to make sure that their kidneys are tolerating it okay, their liver tests are good, and their blood counts are good. If they are, chances are they're gonna continue to be that way because just some kids are more sensitive to these things than others. If they're good, then we usually check the blood work maybe every 6 to 12 months, depending on the child and underlying condition. So those are the anti-inflammatory type medications. And like I said, we're not going to spend a lot of time on these. So the disease-modifying anti-rheumatic drugs. These are the medicines that lower that overactive immune system so that it stops producing the inflammation in the first place. So the anti-inflammatory medicines help with inflammation that the immune system is producing. These medicines lower that immune system so that it stops attacking the joints. It may be the first line therapy if your child walks in with multiple joints, has multiple abnormal labs, and we know that the anti-inflammatory medicine alone is not going to be effective. Many children will start with a disease-modifying medication. Examples of these medications are methotrexate, which many of you I'm sure are aware of. It is given weekly. Leflunomide, or something called Areva, is given orally daily. And sulfasalazine or azolfidine is a medication that's given twice daily. We don't use a lot of sulfasalazine. It depends sometimes on the type of arthritis, and many times your doctors will pick and choose some of these medicines based on the type of arthritis, which we're not going to delve a lot into the many different types of arthritis and which drug might be best for each, but we may mention them. So sulfasalazine or azolfidine is usually used more in the enthesitis-related arthritises. The problem with sulfasalazine is that the pill is kind of big. And so you kind of have to be a little bit older to be able to swallow it. And you can make it into, have like a compounding pharmacy, make it into a liquid, but we have other medicines. So if you can't swallow the big pill, I'm usually in with the methotrexate or the leflunomide. So first we're going to talk about is methotrexate. It can be given orally or by injection on a weekly basis. We usually recommend that they take folic acid or a folic acid pill or a multivitamin with folic acid in it to help prevent side effects to the methotrexate. It can take 3 months to see the full effect from the methotrexate. So sometimes we are using either the anti-inflammatory medications or the steroids as kind of a bridge while we are waiting for the methotrexate to take full effect. A lot of people don't like methotrexate, and when you read the methotrexate side effects panel, I don't blame you. But we have been using methotrexate for over 50 years in children with arthritis with good results. And because we've been using it for more than 50 years, we know the long-term potential side effects to it. We're really good now with the dosing. We know not to go above certain doses before we start to have problems with side effects. And we know that it has no long-term effect on like causing cancer or other long-term things, because there are people who have actually been on methotrexate for 40 years or 50 years. People have been on it for that long. Most common side effects to methotrexate are nausea, fatigue the day after they take the medication, elevated liver enzyme tests, and maybe low blood counts. The increased risk for infection is a thing that we worry about the most. So things like if your child has an infection, a fever, bad cough, doesn't feel well, and they're on methotrexate or any of the disease-modifying anti-rheumatic drugs, the DMARDs or the biologic DMARDs, we don't want to ignore that because the immune system may not be as strong to fight off that infection. So our goal is to lower the immune system enough to stop the overactive immune system that's attacking the joints, but we do risk suppressing a little bit of the good part of the immune system, which helps them fight off infections. We don't recommend that they get live vaccines while they're on the methotrexate. Live vaccines are vaccines that actually have a little bit of active virus in them that has been stunted. So the virus is still there, but it doesn't very effective. But if we suppress our immune system, it's possible that that immunization could actually cause that particular disease. There are very few live vaccines out there. The only ones that are currently used are MMR, the measles, mumps, rubella vaccine, and the chickenpox vaccine. And if your child's going overseas, the yellow fever vaccine, but most people don't need to get the yellow fever vaccine. So just make sure that your pediatrician is aware that your child is on these medications, and if you're due for vaccinations, make sure that we're not getting any of the live vaccines. We will often write, especially if you have a toddler who needs the MMR and able to go to kindergarten, we will write letters for you to say, this child is immune suppressed and is unable to get the MMR vaccine and should be exempt. They can still get all the other vaccines though. So any of the killed or what they call inactivated vaccines, they can get all of those. And probably should, because we want to make sure that our child is ready to fight off any infection that might come to them. I did not put a slide in about the Areva, the leflunomide. This is an alternative to the methotrexate. It is given daily. It has some similar side effects in terms of suppressing the immune system. It can occasionally cause nausea, but not as much as the methotrexate does, and it can still cause liver enzyme elevation. So that is an alternative. It only comes in pill form. It doesn't come in a liquid, doesn't come in as an injectable. And it's comparable to the methotrexate. So because methotrexate has such a good track record, the majority of doctors tend to use the methotrexate. So as I'm going over all of the medicines, and then we'll talk about the treat to target and how that approach occurs. So the biologic disease-modifying medications, these are our designer drugs. These are the things that have revolutionized how we treat our kids with arthritis since the year 2000. They are designer drugs that target specific parts of the immune system that cause most of the inflammation. So when we give things like the leflunomide and the methotrexate, we're using medicines that kind of suppress the overactive immune system kind of in general, kind of suppressing our bone marrow a little bit. These drugs completely block that specific part of the immune system that's causing that inflammation. So we know that when the body produces inflammation, it does it through these things called cytokines. And cytokines are, they sound bad too. They're things that kind of that attack things. And so the ones that we know cause most inflammation are something called TNF alpha, IL-1, IL-6, IL-17, IL-8, and then we have medicines now, except for the IL-8, we have medicines now that block TNF, block IL-1, block IL-6, and block IL-17. We didn't have those before. This is fascinating. So the side effects to them are very limited then, because now we're not suppressing a little bit of everything, we're suppressing all of one thing. So the side effects of the medicines are related to what does that one thing do for your body naturally, because you're gonna suppress it, and are you gonna need it? Okay. So the TNF alpha inhibitors were the first ones that came out. Enbrel or etanercept, Humira or adalimumab, infliximab or Remicade, golimumab or Simponi and Aria. They all block the same thing. So sometimes if your child is not doing well with something like etanercept or Enbrel, and your doctor wants to change them to something like Humira, they may or may not have significant effect because you're just changing medicines in the same class. And so many times we'll recommend that you change it to a different class, because if you block the TNF and it didn't make a difference, then maybe we should use a different class. TNF alpha inhibitors are approved for almost all the different types of arthritis. The polyarticular is effective for the oligoarticular. They work really well for the uveitis complications associated with JIA. And the differences between the four different medicines is how they're given and the frequency of how they're giving. IL-1 inhibitors are really good for the systemic onset juvenile arthritises, and we use them for a few other conditions as well. So we usually don't use the IL-1 inhibitors for kids with other types of conditions other than the systemic kind. The systemic juvenile arthritis kids have the high fevers, the rashes, in addition to their arthritis. IL-6 inhibitors are part of the newer medicines that are out there, and it's called Actemra, and it can be given by IV or subcutaneously. We'll go over these in a little more detail. And then IL-17 inhibitors are good, have just got approved for kids in the last few weeks, called secukinumab or Cosentyx, that helps with the psoriatic and enthesitis-related arthritises. And then we have a few others that actually don't specifically block one specific part of the immune system, they block other parts. One is Orencia, which blocks something called CTLA4. It's like part of the T cell, and it kind of stops that T cell from making some of those things. And then a new oral medicine. So all of these medicines are injectable, and finally now we have an oral medicine called Xeljanz or tofacitinib that can also be used to treat the polyarticular arthritis. And we'll go over those in a little more detail. And then steroids. We're just going over the individual classes. So the steroids, we don't like to use a lot of steroids. Steroids, sometimes children need the steroids to control the arthritis. Usually we minimize those as much as possible. So we want the oral steroids to be used as a bridge to help with pain and inflammation while we wait for the methotrexate or these other biologic medications to take effect. They do have side effects. Long-term use of prednisone or steroids can cause things like weight gain. It can cause growth problems if you're taking them for an extended period of time. It can cause difficulty sleeping at nighttime. Weight gain increases their risk for infection. High blood pressures can cause osteoporosis. So there's lots of things that can happen with steroids, especially if you use them over long term. Over the short term, they're going to be more the annoying things like difficulty sleeping at nighttime, increase in appetite, and some mood swings. The issues with the soft bones and those type of things usually don't occur until you've been on the medicine for over 6 months, but we try to minimize that as much as possible. And sometimes we can use steroids to inject a joint, especially if your child has one joint. So we do have those kids who have that oligoarticular type that have 4 or fewer joints. And if you're fortunate enough to have just one joint and the anti-inflammatory medicines are not effective, a corticosteroid injection into that one joint may allow the child not to have to use these other medications. Sometimes they work, sometimes they don't, but they're sometimes worth a try. Or sometimes we'll do the steroid injections if the child is doing well and if they have multiple joint arthritis and all of their arthritis is under good control, but we can't get that one knee or that one wrist or that one elbow to respond. Sometimes we'll do a corticosteroid shot into that one joint to kind of help us not have to use multiple other medicines and suppress the immune system even more. So a stubborn joint will sometimes use it as well. So what does this treat to target mean? So treat to target is a term that came out of a group called PR-COIN. PR-COIN is the Pediatric Rheumatology Care and Outcome Improvement Network. There's a network of several pediatric rheumatology practices that are working on trying to have more of a standardized approach and have parental and child involvement in our decision making. All of your doctors are treating to target. They might not be calling it that. Everybody wants your child to be in remission. Okay, everybody wants your child to have inactive disease. So when your doctors are helping you make these making these recommendations for the different types of medications, it is in effect what we're trying to do. But if you're in a PR-COIN center, you may hear the words treat to target and may get papers that talk about specifically how that happens. So we're going to talk a little bit about that. So a treat to target approach. Providers and families collaboratively set disease activity treatment targets and then select the therapeutic strategies with the intention to reduce the disease activity to the selected target. So for some people, the selected target might be remission. We want to see no signs of any joint swelling, no pain, no morning stiffness, total remission. And others might say, we've been doing this for a long time, and our treatment target is we want to reduce the inflammation and the pain so that we have inactive disease or very low disease activity so that we can be functional without pushing for remission, which may cause you to use medications that may cause more side effects. So this is but it's considered a shared decision making. So the treat to target approach is a shared decision making. So the treatment targets and the therapeutic strategy should be based on the shared decisions between the patients and the parents and the pediatric rheumatology healthcare team. However, so how do you choose a target? So how do we know when we've reached a target? And it can be a little bit subjective at times. So what the PR-COIN team has used is something called a CJDAS. So aspects are a reliable measure of disease activity called a CJDAS, which incorporates the global assessment. How many people here get papers from their doctors to say, can your child do this and can your child do this, and circle the pain score and circle the how active our disease is? Okay. Part of that is to help give us a little bit more of an objective measure, and we can monitor it from time to time to see how well your child is doing. One of those things that we ask is a parent global assessment. How do you feel the arthritis is affecting your child over the last 1 to 2 weeks? And that score kind of is part of that CJ-10 that we're going to talk about. So we use 3 components. We use the parent global assessment, we use the provider global assessment, and the total joint count. And we get a score anywhere from 0 to 30. And then from there, we decide what the activity is going to be. Usually our objective is inactive disease or remission or low disease activity. And how we determine that is using this score. That's where I talked about provider global score 0 to 10, parent global score from 0 to 10, and active joint score from 0 to 10 to give us a total of 30. In inactive disease, in a child with oligoarticular, we want a score between 0 and 1. For polyarticular, we want inactive disease to be a score of 2.5 or less. So you usually get a diagnosis your child has oligoarticular 4 or fewer joints, or polyarticular 5 or more joints. And then moderate is 4.1 to 10 in oligo, 5.1 to 10 in polyarticular disease, and 10 or more or 15 or more, you have high disease activity. You should be making therapeutic changes. but your score has a significant impact on that treat to target. So sometimes when I look at the score and I'll see the child looks good, I don't see a lot of joint swelling, it seems like they're pretty functional, that check that says that they can do stuff, they can do everything, but the score is a 5 on the parent. So if I see a 5, I'm like, well, we're in moderate disease category. If we're in moderate disease category, I should be making a change in the child's arthritis. And so sometimes I will go back and ask, so why did you make it a 5 when they seem like they're doing well? And many times people will say, well, they have to take all these medicines and their life isn't normal because they have arthritis and they have to take these medications, or they have side effects to medications. But what we're looking for when we're doing these scores is we're looking at how does the arthritis itself affect your child's ability to function physically. So it's more of that's the score that we're looking at. And sometimes that's hard because we look at our child as in the whole. We're looking at their emotional aspects, the fact that they have to take medications, the fact that they're sick on Saturday when they took the methotrexate on Friday. Those kind of things we want to put in as a family into that score. But when we're looking at when you're circling those things, do you think your child needs a change in medication to get better control of their arthritis? That's basically what we're looking for with that score. So an inactive disease means 0 joints, and that the provider and the patient family put a score of 0 or 1, indicating no negative impact currently. So if the CJDAS, that score that we do from the parent, the provider, and the total joint count is not at target, then that's usually when you sit down and say, so what medication should we use? What changes do we need to make to help the child achieve that inactive disease, low disease activity? And so what it is then what is important to you about your arthritis medications? What are we looking for when we're going to make a decision to change our medicines? So these are the things to consider when you want to change the medications. How often is the medication given? So your doctor says, Johnny has 3 active joints. You have a global assessment of 5. I have a global assessment of 4. They have, I can't add that up, but you have a high disease activity. We need to do something more. Johnny's been on methotrexate for the last 3 to 4 months, and we still don't have good disease activity. We need to add one of these biologic disease-modifying medications. Which one should we choose? So these are the factors to consider. How often is the medication given? Some medications are given daily. Some medications are given orally. Some medications are given once a week. Some medications are given every 2 weeks. Some are given every month or every 8 weeks. Some are IV, some are subcutaneous, some are oral. What is going to work best for you? And I sometimes assume that someone doesn't want to have to take a shot, and that Johnny would rather take a pill. But then the family goes, no, Johnny will not take a pill twice a day. There's no way I'm going to get him to take it. He's not going to swallow it, and he's not going to remember to take the medicine twice a day. And I go to work, so okay, we'll cross that one off of the list. Some patients say, absolutely not. We cannot give subcutaneous injections at home. We don't want to give the pill. So then we start looking at, well, what are our IV alternatives that you can come in for? Somebody say, I don't want to come in for IVs. I can't take time off work. It's a long drive. I can't make it for the IVs. So all these things are factors in considering what is the best treatment. So not just what is good for control of their arthritis, but what can we stay on? These medications, when you start them, if they do well, need to stay on them for a long period of time. So it has to be something that you can work with, that you can deal with. You also have to consider, what are the potential side effects? What is the cost? Some of these medications, actually a lot of these biologic medications, are very expensive. Do they have copay cards that go along with it? Are the infusion centers that I'm going to in network, out of network? So what are going to be the long-term costs for some of these medications? What is the severity of the disease? Is it severe enough that we think we want to go into something this strong? And then what is the frequency of the medication monitoring? Some of these medicines we need to have blood work done every 4 to 8 weeks, and some of them don't need much monitoring at all. So it just depends on those type of things as well. All right, so the disease-modifying medications, we're going to go back over those. So remember, we talked about all the different classes, and we went through all of them individually. So we're going to talk about our treat to target. We're going to, most of the time, so there's every rheumatologist, I wish I could say we all do everything the same. We do not. We each have our favorite medicines based on our previous experience. A lot of us look at some of the studies and interpret them in different ways. We do have a consensus treatment plan about the general approach to children with arthritis. Some rheumatologists say, I want your child who has active arthritis to start all of the medicines at the same time. We're going to use a disease-modifying anti-rheumatic drug like methotrexate. We're going to put them on a biologic disease-modifying medication like etanercept or Enbrel or Humira, and we're going to put them on steroids. And once we get the disease totally under control, then we'll start taking stuff away. And then we'll take away the prednisone or the steroids, and then maybe we can lower the dose of methotrexate. But their goal is to get the whole disease process under control all at one time. And then there are other rheumatologists that do a kind of a stepwise approach. We're going to start with the methotrexate. If we don't see enough improvement, then we're going to add the biologic, because if you don't need the biologic medication, why do we have to put them on it in the first place? I'm going to be honest, my thought process is a lot of it is dependent on my insurance companies. And I am sorry, but our insurances, and the reason why we have the Arthritis Foundation and this advocacy is because I have a very hard time getting a patient to get all 3 medicines at the same time. Because most insurance companies say, well, did they try methotrexate first before I approve your Enbrel, your Humira, your whatever the other medication is? And it's very annoying. So by the time I get it approved, you might as well just been on the methotrexate. So anyway, the first line therapy is usually our methotrexate or leflunomide. They lower the immune system so it stops producing the inflammation in the first place. And it is your first line therapy if your arthritis is more severe, or we add it if your anti-inflammatory medicine doesn't work. And as we talked about before, it's methotrexate, which is given weekly, leflunomide given daily, or sulfasalazine given twice daily. And then these are then the medications that we can choose if you have not responded adequately to them. So the TNF-alpha inhibitors, which are your etanercept, your Humiras, your infliximabs, your golimumab. Etanercept blocks TNF by competitively binding TNF in your circulation. So the other ones are monoclonal antibodies. So an antibody is that the drug is an antibody to the TNF and it blocks it. The reason that etanercept has to be given weekly is because etanercept is it competes with the body's own receptors for TNF. And so it binds up all the TNF in circulation, but where it runs out because the body's making more receptors. And so after a week, you need to have another dose. Things like Humira or adalimumab or Remicade or infliximab is that they're monoclonal antibodies, so they block it at the cell site as well as at the receptor site. So they block it wherever it is. So it seems to last a little bit longer in the system. All of the TNF-alpha inhibitors are given either by injection. So etanercept is an injection once a week. Humira, adalimumab is every 2 weeks. And infliximab, Remicade, there's a bunch of biosimilars, Inflectra, something else. They all seem to be biosimilar. They're very kind of equivalent, so they seem to all work about the same. The infliximab is once every 4 weeks to once every 8 weeks, and again, it depends on the severity of the child's disease and how fast the medication wears off. And then golimumab is a little bit more recently approved for children, and it is given by either IV or sub-Q, and that's also once a month. It's a once a month sub-Q. The IL-1 inhibitors anakinra is not the favorite of our kids with systemic JIA because it is a daily shot. a daily subcutaneous injection. It works phenomenally well for the fevers, the arthritis, the rashes, and the inflammation. And then canakinumab or Alaris is a once-a-month injection. So it's one of those monoclonal antibodies. So the Kineret is a receptor blocker for IL-1, similar to etanercept, but it doesn't last very long. It lasts for 6 to 8 hours, so you have to take the shot every day. As opposed to canakinumab, which is a monoclonal antibody, and it lasts for a month, maybe even 6 weeks, depending on the type of condition that we're looking at. IL-6 inhibitors are usually used once the TNF inhibitors have not been effective, or can also be effective for the systemic JA. This one is given also by subcutaneous injection at home every 2 to 3 weeks, or by IV once a month. And a lot of that is just dependent on your own, what you would like to do, what your insurance is willing to pay for. Would you rather give injections at home? They seem to work similarly whether you give it by IV or sub-Q. IL-17 medicine, the Cosentyx, just got approved for enthesitis and psoriatic arthritis, was approved for the adults. It is a subcutaneous injection. It only has to be taken once a month. And then the abatacept is an IV medicine called which is also given once a month. And then the oral Xeljanz, which is given twice a day. So the Xeljanz, I want to go back. So the Xeljanz medication, I thought I had a slide on it, and I don't. It's relatively new. Because it is an oral pill. In adults, they have an extended release form where they only have to take it once a day. But because all the studies in kids were done giving the kid twice a day, we can only give it twice a day, and we can't get approved to do an extended release once a day medication for them. So it's given twice a day. It blocks the inflammation inside the cell. So almost everything else seems to try to block from the outside to prevent those cytokines from causing the inflammation in the cell itself. These medications are called JAK kinase inhibitors. They work from inside the cell to stop the inflammation. In adults, there's been a lot of reports of increased risk for heart attacks and blood clots. We have not seen that issue with children, mostly because children have a very low risk for heart attacks and blood clots in the first place, but you just need to be aware. So if you're 60 years old, high cholesterol, diabetes, smoker, you don't want to be on Xeljanz, okay? But if you're 2 years old and you're otherwise healthy, you're not going to have issues with heart attacks or strokes or blood clots, but you just need to be aware of that. The other side effects, again, suppresses the immune system. It works fairly quickly. It has been reported to cause tears in the intestine in adults. Again, have not seen that in kids, but it might not have been out long enough to have seen that in kids. So if a child who's on Xeljanz has severe stomach pain, we need to know about that. It can raise the cholesterol levels, so we want to monitor the cholesterol, and it can affect the liver test. So it does require blood monitoring, just like all the other medications do. And all of the patients who are taking any of these medicines have to be screened for tuberculosis before they start it, because all of these things can reactivate tuberculosis. So there's many, and hepatitis and all those things. Most kids have been immunized against hepatitis, so usually that's not as much of an issue for our kids with, because of that. So then the next question is always, okay, we've achieved remission. We have picked we've picked our medicines. We've gone from this one to this one, and we finally have achieved remission. And it is not uncommon for people to change from one to the other when one doesn't work as well as something else. But you have now achieved it. Your child has. You give them a 0 or a 1. Doc gives them a 0. They have no active joints. They're participating in most of their activities. They might have a little pain if they do a little bit too much. And then the first question is, so can we stop the medications? That's a really tough question. We don't really know the answer to when is the right time, or when can we stop medications. There are multiple factors that go into deciding whether or not a child should come off of medications, and when, or if they should come off of them at all. So there are multiple factors, including the type of arthritis. So usually the polyarticular type of arthritis, tends to have more likely to have longer disease activity, and so we're maybe less inclined to have them come off of medication. You may be able to lower or get down to monotherapy, which is just one drug. So many times we have kids on methotrexate and Humira, or methotrexate and Remicade infusions, and sometimes we can wean down either the dosing of the methotrexate or even wean them off of it altogether. Other factors such as the uveitis. Uveitis is much more difficult to control than the arthritis. So if the eye inflammation is very active or has been active in the recent past, we want to make sure that that has stayed inactive for an extended period of time, because that's the first thing that comes back whenever we try to lower their medications. So ongoing research will help make some of those decisions. The general consensus is that if the kids have started their arthritis at the between ages of 1 and 3, have 1 or 2 joints involved, responded really well to medications, and have no problems with uveitis, they're the ones that can usually come off medications. Our older kids who got it when they were, school age or teenagers who have multiple joints, we find that they tend to follow the same path as the adults, that if we try to stop their medications, their arthritis tends to flare. And all we are doing is we're controlling the arthritis. We are not curing the arthritis. But there is ongoing research to help determine some of these same factors, like who, when, where, and how much can we wean kids off of them. And so if you are in a CARA registry participating site, thank you very much. CARA is the Childhood Arthritis Research, CARA, Childhood Arthritis Rheumatology Research Alliance. And we have a registry where we've enrolled over 10,000 children with juvenile arthritis, and we're following them for 10 years to learn about their long-term history. We're not giving anything experimental. Whenever you come in, you fill out the forms to say, how active is your child's arthritis? We get information about how they're emotionally responding to it, how their physical function is, and then we take in all of their medications. And we're looking for, are there patterns to people doing better with certain combinations of medicines? Is there timing of when some kids get taken off medicine? And because you're enrolling in from pediatric rheumatology from Seattle to Canada to Florida, we're kind of covering the whole country and seeing how, because like I said, every rheumatologist does it a little bit differently. So we'll get ideas of how these medications work and who gets in remission and who doesn't, and side effects and all those kind of things. So we're learning the long-term arthritis role by being part of this CARE registry. We're trying to learn the answers to these questions. So I left a lot of time for questions because I know there are a lot of questions about this. So we have a whole half hour to ask questions about the treat to target, the types of medications that we use, questions that you might have. Yes, so if you have a question, if you wouldn't mind coming up to the microphone, that way we can, and if you could say your name and where you're from.
Okay, my name is Venus and I'm from Florida. And my question is in relation to the black box warnings on Enbrel and the other biologics.
Okay, so the question is about the black box warning on the etanercept, Humira's, all the TNF inhibitors. So the black box warnings are related to, I believe, the cancer risks. The cancer risk was seen in adults with rheumatoid arthritis. So when these studies were first done back in the 1990s and 2000s, the medication was originally given to adults with active rheumatoid arthritis who have had them for years. We know that patients with rheumatoid arthritis who have had active disease have a higher risk for lymphoma compared to the general population. When they did the studies, the FDA says we want you to monitor for cancer risks as well as all the other potential side effects to these medications. And they found that there was an increased incidence of lymphoma in the patients taking the medication compared to the general population. not compared to other people who have rheumatoid arthritis. And since we know that there's an increased risk for lymphoma in the rheumatoid arthritis patients, if you kind of compare that, it ends up being the same. We've done safety data on children, so again, these medicines have been out for 20 years now, and we have not seen an increased risk of lymphoma in children who take Humira compared to the general population of other pediatric patients. So that risk, even though they don't take away the black box warning. Once they put it on there, it is there to stay. So we do not have a concern about risk for malignancy or lymphoma in children who take the TNF inhibitors.
Thank you.
You're welcome.
Hello, I'm Heather. I'm from Atlanta, and I have a 19-year-old with multiple diagnoses. So what is your feeling on, now that he's an adult, taking multiple biologics for the different diagnoses that he has?
Okay, so basically it sounds like the question is, can you take more than one biologic disease-modifying medication at the same time? There is a risk if you're taking more than one biologic. So we know that we can do a non-biologic disease-modifying medicine like methotrexate, Arava, sulfasalazine, and add one of the biologic disease-modifying medication, a TNF inhibitor, IL-1, IL-6, Xeljanz. But they have found that if you put two biologics together, let's say TNF isn't working all by itself, and maybe if we add IL-6 blockade, we block two things, they'll do even better. They do a lot better, but the risk for infection tends to go way up. So the recommendation is that you do not combine two biologic disease-modifying medications at the same time.
Thank you.
You're welcome.
Hi, I'm Taylor. I'm from Michigan. So I've read a couple things that with the overturning of Roe v. Wade, there's a possibility that it's harder for females to get methotrexate. In your experience, if this happens, would they need to switch medications off of it if they can't get it, or what do you think would happen? I don't know.
It's really hard to predict the future. That is another reason for our advocacy at both the Arthritis Foundation level and through the American College of Rheumatology, is to try to prevent things like this from happening. So there have been rumors, and I think a couple pharmacies in a couple states refuse to fill methotrexate for patients who have rheumatoid arthritis because of the potential for it could be used as an abortifacient. So that has not been across the country and has not been a statewide mandate, but there have been a few pharmacies that say, I don't know, and I don't want to get in trouble, and so I'm not going to refill your medication for you. We are advocating very hard to make sure that that doesn't happen. It is basically used to treat an autoimmune disease. Yes, but if they take it away, it's going to be a challenge. And a lot of our other medications cause problems with birth defects as well. So if I know that methotrexate can actually be used as a medicine on a short term to cause an abortion in a early term pregnancy, but it also causes problems with birth defects if you get pregnant while you're on the medication. Well, so can leflunomide or Arava, so can mycophenolate, which is another medicine that we use for arthritis and lupus. So it's going to be a challenge, and advocacy is our best way for making sure that these things don't happen. But yes, they'd have to change.
Okay, thank you.
My name's Peter. I'm from Minneapolis. When it comes to going from one drug to the other, how do you know which inhibitor to go after?
That is a great question. We don't know. So sometimes the different types of arthritis, your rheumatologist can help guide you in that. So we know that the systemic type of juvenile arthritis does better with IL-1 and IL-6 inhibitors. We know that patients who have the psoriatic or enthesitis-related arthritis seem to do better with the TNF inhibitors or the IL-17 inhibitors. But which one to choose first, which one will be better? Every child, every adult is different. And if everybody could be the same, it would really be super helpful if everybody responded the same way to the medications, but they don't. So a lot of it is, it's basically our best guess. And then a lot of times using, what do you think you're willing to do? So sometimes medications don't work because we can't get the kids to take the medicine, or families don't want to give the medicine. And so we only get like medicines in half the time because, it causes side effects and we don't want to be on them. So.
In which case I'll ask, I'm assuming there's just no way to test for a particular inhibitor?
There is under research, there is ways of trying to find out, you're talking about precision medicine. We are working, there are studies ongoing looking at things like what they call precision medicine, which is you do a blood test on someone and you see which type of, does your child make more TNF, does your child make more IL-6, does your child make more IL-17, and then be able to pick your drug based on that. And also whether or not your child is a metabolizer, a good metabolizer for the medications. There is a blood test that does look at metabolizing methotrexate and whether you're a good metabolizer or not good metabolizer, which could increase your risk for side effects. There are some doctors that do use that testing, but it is a genetic test. And again, insurance companies don't like to pay for these things, so it tends to be part of our issue. But once they are working on looking at being able to detect those things in circulation, but there is no commercial product yet available to help us define which biologic would be the best, but that doesn't mean that that's not coming. So, I expect within 5 years that we may have something like that will help you choose. And that would make, I would not see our insurance companies denying that, because why do you want to spend a ton of money on a medicine that's not going to work if you do a test that says this child has the best chance of responding to an IL-6 inhibitor? But that's just me. But I live in the real world, and the real world is that I have to deal with these insurance companies. But
Yes, I'm Melissa. I'm from Florida. My question is more about coming off the medications. My daughter's 11 now. She's diagnosed with oligo-JA originally, and then she developed uveitis. So she was on Humira for 8 years, and then doing really well. We finally decided to come off, and then within 2 months, she started again with the symptoms. So now we're working on finding something. We're just gonna start Symphony, but my question is, will she ever come off of the Symphony or whatever works for her, or would that be more like just to prepare her for lifelong medications? Or we don't know, I know, but kind of my question.
Sure. So that is often what we'll do, is that if a child is doing really well, my rheumatologists will pick a time frame, a year, 6 months, 2 years of disease remission before they'll decide it's time to try to stop medicine and see how the child does. I usually pick 2 years. I like 2 years of no disease activity while on medicines, because inevitably something happens where you'll have to miss a dose, or they get an infection, or something will happen where you have to miss a dose, or they could be potential triggers for the arthritis. And if it doesn't flare during that period of time, I'm like, well, 2 years, nothing happened. Let's go ahead and see if we can start weaning you off of medications. If they do flare and we get the disease back under control again, I start the clock back for the 2 years. Once you get back into remission, I wait another 2 years, and then you come to a decision point. Is it if your disease is doing really well on the medicines, do you really want to risk them flaring and having to go through that process all over again? And especially if they're not having any side effects. So it becomes a decision point time. Second thing is, I have found that, and this is my own personal experience, there's no data, so don't repeat this. I know it's being recorded, so it's going to be repeated. Once you go through puberty, your immune system has kind of been set. And so the likelihood that your disease is going to go into remission drops down, off of medicines, drops down significantly. So like our adults who have rheumatoid arthritis, we find that only 5% of them can actually come off medications. Usually they will flare within 6 to 12 months of discontinuing medications. And so using that adult data and seeing what's been happening with our kids, usually the recommendation is that if they're a teenager, the likelihood of them coming off all medicines is low. It doesn't mean they can't come off some or beyond the minimal amount of medicine. But my mentor told me, don't poke a skunk. If your child is doing well on medicines and is not having any side effects, why do you want to go and poke that skunk and have it spray you and have all these issues? So I kind of use that as my adage, just don't poke the skunk.
Hi, I'm Alana from Florida. You actually see my son. He has been on Humira and methotrexate, and a year ago he wasn't walking at all. He's doing very well, but he's not actually tolerating taking the injections anymore. So my question is, would the oral route be as effective in somebody as severe of a case that he has?
So great. That's a question to talk about when we're in the appointment. But actually, we can talk about options. So if you picked option this and that, and you said this is great, it's working well, they're tolerating everything, and all of a sudden it becomes intolerable, then that's when you can talk about changes in medication. So the oral Xeljanz, again, we usually want to change within that specific class. So if the methotrexate is no longer tolerable by injection and you want to move to methotrexate orally, you could do that. You could change your methotrexate to the Areva, but you want to keep that within that same class. If it's the injections like the Humira that are no longer tolerable, then you want to talk about, do you want to go to an IV in the biologic category, or do you want to go to that oral Xeljanz? And as long as you're, okay, I can't make it go backwards. I think they shut me off. There we go. So if you kind of stay within that class, so if you're in a biologic and you want to change within that class and you pick something else within that class, if you're in the non-biologic DMARD and you need to change it, then you change something within that class.
Thank you.
You're welcome.
Good morning, Doc. Thank you for being here. Jason from Houston, Texas. You just made a comment about puberty. I've never heard that before.
I know, it's my own theory. That's why I said they're probably, so don't quote me on that one.
Well, I'm gonna quote you anyway. Son's 9, less than a year diagnosed. So coming up on puberty, he's polyarticular. If we can gain remission before full puberty hits, what are the odds of not being lifelong medication-wise?
So like I said, puberty is when your immune system, I feel, fully develops. So right now the immune system is kind of it's wanky. It's attacking this and attacking that, and it doesn't know what it's doing. But as the body matures, the immune system matures as well. So yes, he has plenty of time. So once the disease gets under good control, you can keep it there for an extended period of time. He does his big growth spurt and becomes a man. At 13, then maybe you could try to wean him off medicines and see what happens. And at that point he flares, and you're like, the likelihood that when you try again at 15 or 16 that he'll be able to totally stop medications again will be relatively low. But yes, there's absolutely it's early. It's way too soon to say whether or not he can or cannot achieve a remission.
Just thinking odds.
Sure.
Hi, doctor. Thank you so much for your talk. Marisa from Chicago. So if a child is doing well and in remission with a TNF alpha inhibitor, stops the medication, and when a flare-up comes back, what is your thinking or recommendation about going back to the same type of medication or trying something different?
So if your child was in remission on a specific medication and then you stop the medicine because we're hoping that they're in, remission, and we won't have another flare and they flare back up again, I usually go back to the same medicine that worked, right? It worked before, it should work again. There are some patients that for some reason they don't respond to the medication when they go back on it. There have been a few patients who have flared and their disease actually ends up being worse than it was before we, stopped their medication. So there is that particular risk where they end up on more medicine after than they were, before they went into remission. So I've had a few kids that they did really well on just TNF inhibitor. They did really great. We're going to stop the medicine. The disease flared. We went back on the TNF inhibitor. And then they needed methotrexate with it or had to change medicine. So, but usually I go back on the same one that worked. I mean, if it worked before, most of the time it works again. It's just occasionally it doesn't.
Thank you.
Hi, I'm Jennifer from New York. So my question is, what happens when the kids seem to have exhausted all of these? Like, what's next? Is there something in the works?
So the question is, is there anything else? There are off-label things that I did not talk about because this is, general public type of talk. There are medications that are FDA approved for adults that are not FDA approved for kids that we can get off-label. So there are definitely other off-label medicines that we use. And thank God we have pipelines of medicines are constantly occurring. Like I said, 30 years ago, when I went into my rheumatology fellowship, we had methotrexate, gold shots, penicillamine, and steroids, sulfasalazine, Plaquenil. That's it. So now, and then the TNF inhibitors came out, and that's all we had for a period of about close to 10 years. And now it's been a gold rush of all kinds of new medicines that are coming out and new drugs always in development. So there's always something else, coming out.
Thank you.
I hate to barge in, but we have several great comments from the web. If I could read the first one. Amy asks, what can you share about now young adults who were on methotrexate and leflunomide as children, specifically regarding fertility? For example, a child who was on methotrexate and Avera from age 8 through 16 and is now a young adult. As in, will DMARDs have an effect on the young adult's ability to conceive children?
That's a great question. So we have not found that the leflunomide or the methotrexate has an effect on fertility itself. If a child or young adult gets pregnant while on the medication, it will cause problems with birth defects or cause an early miscarriage. So the recommendation is that if you are trying to get pregnant, you are off the methotrexate for at least 3 months before you would attempt to get pregnant, to make sure that the medication is out of the system and will not have an effect on the unborn child. Leflunomide has a little bit longer half-life, and so it stays in the system for much longer, and it is recommended that they take a medication that binds the medication. I think it's the cholestyramine. So you would talk to your OB/GYN doctor and get placed on, or talk to your rheumatologist and get placed on this medication that will basically bind all the drug in their system so that they would have no effect on the child. But it has no effect on their ability to get pregnant in the future.
Thank you. That's it so far, actually. It was just one comment.
Okay.
Hi there, my name's Kay, I'm from Wisconsin. So I actually have arthritis myself. I'm 21 right now and I've had it since I was 10. So I've gone through a fair number of these medications and I'm kind of wondering, is there a reason that they may work for maybe a year or 2 years and then stop working?
Great question. So why do the medicines sometimes that seem to be working beautifully all of a sudden stop working? Well, we are learning that the immune system is very smart, and sometimes it will make antibodies against the drugs. So we have found that there are some patients who, like those monoclonal antibodies, the body sees those antibodies and says, oh, I don't like that one, and I'm going to attack it too. So sometimes, especially the infliximab and the adalimumab, so the Remicade and the Humira, we know that the body can make antibodies against those. We actually have commercially available blood tests to check to see if you have those antibodies. So if a medicine stops working, we can check to see if you have the antibody. If you have the antibody, then it's like, okay, we probably need to stop that medicine because it's no longer going to work for you. If you don't have the antibody, then it could be just that your disease becomes a little bit more active. So the immune system's a funny thing. So sometimes it's, does a little bit of activity and then all of a sudden it'll decide, no, I want to attack even more. And like, why? So it tends to go up and down. So sometimes you're under good control on the medicines and then the immune system just decided to attack more. So sometimes it's because your body has gotten used to, we say gotten used to, but it's probably they made antibodies. Many reasons why patients are on methotrexate with their Humira or adalimumab or methotrexate and the Remicade is to help prevent those antibody formations, because we have found that if you take the methotrexate with your, especially the Remicade infusions, we tend to have less issues with making antibodies. So that's another reason why you have to stay on the methotrexate.
Awesome, thank you.
You're welcome. I'm available to talk for a few minutes afterwards. Thank you so much for your attention, and I appreciate the warm welcome.